Well, now, one of the best things about this health summit every year is hearing about all the remarkable new innovations in technology, the whole aim of which is to deliver better healthcare. And we're going to hear now from the CEO of HN and one of its data scientists. HN uses artificial intelligence, AI, to predict and prevent care needs. We're joined here in Dublin today by its CEO, Mark England, data scientist Sara Reis, and also here is Professor Matthew Cooke, who's an advisor in digital health, emergency care and innovation. He was formerly the Urgent and Emergency Care Czar for the UK government, and he's an experienced A&E physician. Please welcome them.
Thanks very much. So thank you very much, and thanks for your time and attention today. I'm Mark England, as it's been said. My background is non-clinical. I'm CEO, but I came into healthcare as a Chief Information Officer. I'm a software engineer, data background. But after many years of digitising healthcare, I became interested in wider roles, and I became Executive Director for Operations and Transformation in an acute hospital, Managing Director of an integrated care system in the NHS in England. And my last role was Deputy National Director of UEC, the policy role in the centre. So we're going to talk to you a bit about, Dr. Glynn mentioned the AI was on the rise, etc., and we're going to try and make it real and give you some context about why you might want to use AI and how you could use it effectively today. So just to a bit of background to HM, we're originally from Scandinavia. I joined them about 3 years ago from the NHS. Two sides to the business, a data science side represented by Sara, but we also have a team of nurses who deliver a person-centred telecoaching intervention. And we've got a range of academic partnerships, and I'm a National Innovation Accelerator Fellow in the NHS as well. So a bit of the background there. Now, just before we get into the detail, the unscheduled care pressures, we've heard a lot, people talk this morning about epidemiology and demography and the rise of demand, but I think it's worth just pausing and taking a sort of 10-year plus horizon around the problems we're facing in unscheduled care. This is an English graph. The red line is the 4-hour target in England, and the black line at the top dotted is the target, 95%. And you can see there's a little spike in the middle where we had some good performance during the pandemic, where it started to rise up again. But the long-term trend is clear. We've been struggling with epidemiology, demography, and the demand, as Tony was saying, and the structure of the demand. And it's got to a really critical stage where the paper that Brian mentioned this morning around the excess deaths, for every 82 patients who wait longer than 6 hours in ED, there is one additional death. We estimate we're running at between 400 and 600 excess deaths a week in England at the moment. So in Ireland, similar situation, just looking at your trolley weight counts, you've got the same trend, slightly bucked in the middle by COVID, but you've got the same trend. But you've got a plan, right care, right time, right place, launch of care. And I think what we're going to talk about now, about why you can use predictive analytics and how to use it, is relevant really when you're mobilising your programme at the stage you are now and how you allocate resources effectively. So I'm going to hand over to Sara Reis, our data scientist, and she's going to talk around some data from Glasgow about unscheduled care demand. And in particular, she's going to talk about people. We count a lot of things in healthcare, trolleys, A&E waits, etc., outpatient appointments, but she's going to talk about individuals within the population.
Thank you, Mark. So as Mark mentioned, I'm going to present some data that we worked with some time ago. So 3 key messages. Unscheduled hospital care demand is concentrated to a very small population. Our data set was comprised of the whole population of Greater Glasgow and Clyde Health Board. It's the largest health group in the UK, and it caters or provides healthcare for over 1.2 million people. What we saw from their data was that only 5% of the hospital population, that's about 22,000 people, consumed over 80% of the non-elective bed days, so unscheduled, unplanned bed days at the hospital for a particular year. It's been mentioned before, the clear link between deprivation, inequality, burden of chronic disease and unscheduled care needs with high levels of unplanned consumption. There's a clear link here on the geographical distribution of these high users, frequent users, and where they live and how deprived their area is. And a second key message is that this unscheduled hospital care demand is transient. So what we've seen in Glasgow, but also in other regions in the UK, is that from 1 year to the next, this group of high consumers changes very quickly, which means that typical or standard ways of identifying these patients don't usually work, because at the point of identification, these patients have already hit their highest level of consumption and wouldn't be suitable for any sort of intervention. So with HN, we've basically have demonstrated that this unscheduled care consumption is predictable. So our prediction model can identify 8 of 10 high users before they become these high users. We use routinely collected hospital data. We have validated model performance. We've run an RCT in various regions in the UK with over 1,800 patients. We have paid a lot of attention to test for equality and fairness, particularly for socioeconomically disadvantaged groups. And we developed this technology to be securely cloud operated, scalable, which means it can be deployed fairly easy, never easy, but fairly easy into a healthcare system. Thank you, Mark.
Excellent. So thanks for that, Sara. So what does that mean for proactive care and slantia care? Come on, sit down, so you're right. So traditionally, when we think about putting in place, a proactive care model, a step-up virtual ward or proactive case management, if, as in Glasgow and as we've seen in Stoke-on-Trent, in Yorkshire, in East Kent, if for 70% of our high bed utilisers, the problem that 84% of bed days being consumed by that cohort, if they're going to have a red line like this, where over 12 months they peak their consumption, the traditional approach is to wait for referral or to have a threshold-based approach. Who's had 3 or more emergency admissions and got condition X, Y, or Z? And then you refer them into traditional case management. Now, if you look at that with before and after analysis, it can look great. It can look like you're having a really big impact. But I think, having worked in the system a lot, we often see results are presented to say this is a great intervention, it's stopping front door activity. But the front door never gets quieter. So we believe there is a different way. Whereas if you use those routinely collected hospital data, as Sara described there, you build a model that can predict 8 out of 10 people who will be on the trolleys, there's a possibility to actually intervene earlier and to provide care proactively, to predict and prevent, as was described this morning. So we've done this in the UK, and we've done a large trial of, as Sara mentioned. So you predict the patients, then we have a team of nurses who are on board, and using a Scandinavian model, they coach the patients to self-support, true shift left, on the telephone, so it's digitally inclusive, particularly for this cohort who can be quite digitally excluded, and then we evaluate it. That's what do they do with the patients? They spend a lot of time dealing with motivation, this group of patients, and health literacy and understanding and wanting to take more control over their own health. And we've got tools which support the nurses on the telephones to do that. I'm going to ask Professor Matthew Cooke to talk more about the results and the evidence, but it's a 2,000-patient trial across 7 sites, and there's a series of publications, some of which we've got on our stand outside, peer-reviewed manuscripts. I'm going to hand over to Matthew. Just before I do, I just thought I'd put this graph up, because Matthew was the SAR for New Labour, and this was a period when he was in office from 2002 to 2005. And in those days, the target used to be 98% people through the department in 4 hours. He was known in England as the father of the 4-hour target, but during his period he saw it rise from 76% to over 95%. Those were the days. We've now set a target in England to get to 76% next year, which is our aspiration.
Thank you, Mark, as the number one member of my fan club with that graph. and certainly the last 20 years plus that I've been involved in the 4-hour target as my baby has seen dramatic changes. The first 10 years of this century saw massive process change. We had collaborative events where every emergency department came along and planned what new processes they were going to do and implemented them. And why did that work? I think what Brian said just a few minutes ago is the absolute thing. It's because people came and they wanted to do it and they were empowered to do it and they enjoyed doing it. That sense of feeling that I've achieved something. You know, people were really proud that in their department people weren't waiting. And to me, that was the most single important factor. That was then followed by 10 years of deterioration up to today. And don't be fooled by the people who say it's due to COVID. As you saw in the graph, COVID was a blip. It was going down beforehand and it's carried on going down since. And what are we trying to do in the UK? Well, let's keep doing more of the same. Well, you know, there's a bit of common sense there. If it hasn't worked for the 5 years, just carrying on doing it is not likely to work. So we need to do something different that hasn't been tried before. There is an obsession with trying to reduce the number of people coming through the front door. And we've singularly failed that with a few exceptions. Lots of publicity campaigns. Don't come to ED, it's really busy today. You know, how many times do you see that on social media? If you were an advertising executive, you would know that any publicity is good publicity. It's brand awareness. So actually, all this publicity saying ED may be increasing brand awareness, and therefore people will go. Because it certainly hasn't stopped them coming. There's a few examples where we've decreased attendance, and that's nearly all around long-term conditions. And actually, when you go into it, the bottom line is it's about empowering patients to look after their own condition so that that shift to the left occurs away from hospital management to supported management or even as far as self-care. So why aren't we investing in that shift to the left to get people being able to care for themselves with chronic disease? Because the big increase in numbers that we're seeing in EDs is nearly all people with multiple conditions. The minor injuries, the minor illness that comes through, it takes me 10 minutes to deal with one of those people. It takes me 2 hours to deal with somebody with multiple conditions who has an acute episode. And those are the people, if we empowered them, wouldn't be coming in so often. What if we could predict and prevent that attendance, that use of health facilities? And I'm not just talking about what Mark was saying. The whole concept of predictive analytics, we used it a lot in COVID, and it gained a bit of credibility. So I'm hoping this is one of the things that will keep credibility. I mean, the credibility was slightly spoiled because it was used by politicians, but people understood that there was a graph heading in that direction. The likelihood is it's going to keep going that way for a bit unless something happens. And that actually, as the incidence of COVID flattened off, people knew where it was going. They were predicting. So we can use prediction for individuals. We can actually use prediction for, very accurately, for how many people are going to come through the door to GP. Yeah, it's more accurately than most people realise. We can actually predict which individuals respond to a treatment. So rather than having a clinical guideline that says everybody with asthma has this drug, we could start predicting this sort of person would respond to this drug this to another. There's massive potential. But before I get carried away, because you gather I'm a bit of an enthusiast on predictive analytics, there are a few things we need to do. We introduce technologies and we believe them. I was brought up, my start in the academic life was just at the time when evidence-based medicine was coming in. And we looked hard at what evidence is there. And we're not using that same approach with technology and with AI and with predictive analytics. So we need to understand how good is the evidence supporting this before we just blindly accept it. Any technology needs to be seamlessly integrated. A good technology, you don't know it's there. You just start to realize life's getting easier. And how many of you use a technology that makes your life easier, and how many of you think, oh, this makes life really difficult? So before you adopt it, ask, is it easy to put it in place? Will people notice it for a good reason, or will they be cursing? My wife's a community nurse. An hour every day at the end of the day, she comes home and taps on her computer with an hour of mumbling because the system she uses is so awful. And it's saying to me, what's the future of predictive analytics? A year ago, I'd have probably given you a long speech about that. Now I'm just going to be honest, I don't know. Because I keep finding things that could be really useful to predict. So I don't understand, at the moment it seems limitless, but there must be some limits. So Mark mentioned about the AI-guided clinical coaching. And just want to use that as an example of good evidence. So RCTs, the highest level of evidence, have been produced. This is really unusual in technology. And when I was asked by the founder of HN, would I join their advisory board, this was one of the things that really attracted me, was having that proper approach of using evidence. So we know we can identify 80% of the high users 4 or 5 months ahead of them becoming a high user. So the challenge isn't finding them. We can do that. Somebody earlier said about lack of data. Anybody who says there's lack of data in healthcare, I'll use the polite word in this company, I challenge vigorously. We have loads of data. The challenge is, what's the quality of it? Well, if you don't use it, it's poor quality. If you start using it, it gets better. If you do. But also, we can't bring the various bits of data that we need together is the biggest challenge. So I would challenge you if you say you haven't got the data. I suspect you probably have got the data, but it's hidden away in all sorts of places and not brought together correctly. What we showed with these RCTs is that there was a definite decrease in demand. So 30% less acute episodes for these people who have some sort of long-term condition. That means better resource usage. But interestingly, it actually results in improved mortality, particularly in lonely old men. That's probably related to the coaching element of it and their usual reluctance to make contact with healthcare. So we've got good evidence that it works and that it can be easily implemented. Also, whenever you're doing a technology, look at these things. Actually, staffing is really important. We've mentioned about the shortage of staff. The return on your investment for hours of nursing time invested is really good for this, but also think of technology as enabling certain staff to come back to nursing. The people we heard about earlier who want to live outside the city, that's no problem when it's telecoaching. They could be anywhere in the world. Those nurses who've escaped from Ireland to Canada. I was in Canada recently and they were telling me, they've got big campaigns of advertising over here. And they're obviously being successful. But you could actually still have them living in Canada and doing some of this work. So people would still hear an Irish voice on the end of the phone, not realising that person was in Canada. People who are burnt out from the face-to-face work, there's plenty of those. People who have retired early. Confession. May go back to doing some of this work because it's so much easier for them. The timing of the interventions is critical. We need to get in early. We need to make sure that we're not intervening and just following the natural history. If you've already had 3ED attendances, the likelihood is it'll decrease anyway. We need to be able to scale this. So one of the questions I would ask if I was in your shoes is, well, your RCTs in Scandinavia and in England, will it apply in Ireland? The answer is, I think it'll apply in any public system, but the first place that uses anything adopted from abroad must test it and make sure that it is work and is tweaked to enable it to work. And it needs to link with your policy in this country. So there's lots of things where one of the biggest mistakes I would say in the UK system, and from friends who work here, I suspect it occurs here, is this belief of one size fits all. This can't just be lifted from one country to another. It can't be lifted from one county to another. A good technology has a core structure and then is adaptable. So I've talked generally about technology. I've talked generally about predictive using HNs, AI-supported clinical coaching as an example. But I do strongly believe that we've got to do things differently. We've got to use technology. I acknowledge new technologies come out. I have to be the first person to use them. I've been really late. I'm only just in the process of buying my Tesla because it's got so much technology in it. We need to change our approach to technology, just like Tesla has changed it. Tesla is a technology company who happens to make a car. And that's what was the really big change. Everyone else is a car company who uses technology. How do we get so that we really use technology well? And I think foremost amongst those is predictive analytics. You wouldn't drive your Tesla or any other car without looking at the road in front of you, knowing what's about to happen. You have less accidents if you look 3 cars ahead for the brake lights. And in healthcare, so often, we're in the ED and it's busy. And the reason it's busy is because, it's a Monday. And I didn't expect a Monday to happen after a Sunday this week. We fail to predict in a massive scale. The opportunities, if we really get prediction, of being able to adjust staffing levels, of being able to adjust our system, being able to adjust our care so that it's appropriate for that individual, are massive. With that, I'll hand back to you, Mark.
Thanks a lot, and thanks for that, Matthew. Your thoughts on that? So just to conclude, appreciate we're up on the limit. So just the model around prediction and using prediction to prevent. We think you've got a population of 5 million. You've got a concentration of probably 50,000 individuals you can make a massive impact upon. If you're making that impact upon the outcome for those 50,000 individuals who are probably consuming 80% of the unplanned bed days, that's the art of slant care. How could we improve the outcomes and get it right for that cohort? Because if you get it right for that cohort, everything else will look after itself in terms of getting the care model right, because the capacity and the bandwidth will be there. So we think predicting and preventing is key. We're outside on one of the stands. Come and see us, come and talk to us. We're very interested to talk to you about your data and the potential in Ireland to support slant care. Thank you very much.
Thank you very much. Thank you, Mark.